Hello everyone. I want to do a nice sort of succinct video clip for you guys regarding transfusion therapy. There is some component of this in your book that you may want to review through as well, and I would, as I had stated in class, please make sure that you do pull an actual policy on transfusion therapy that is specific to the clinical agency that you're in, and just take a look at that, because that'll give you a good idea of kind of how the process works in the setting that you're in. And you'll want to do that every single time, because sometimes policies differ from facility to facility, and sometimes they may even differentiate between certain departments within the hospital. And I'll mention some of those reasons soon. Here you just see a picture of a what we call packed red blood cells. And you will know that you don't get a whole lot of exposure to this in clinical, and it's because transfusion therapy is so precise in that patients have got to be typed and cross-matched to make sure that they really are receiving the blood that they can receive without having a reaction, and that patients are properly identified and it is the correct patient, that the bag itself is within date and not expired, and that there is a match. There's all these checks and balances that take place to verify blood and to administer it safely. And because it's a high-risk situation, only registered nurses are really allowed to do that in most facilities in terms of hanging blood and being the responsible one to start a blood transfusion. And so I'm going to talk a few things about of what's required and how you would get ready for that, but just know that most of our agencies that we do clinical in will not really allow you to participate in that process unless it's just under the direction of the RN to maybe get vitals or do some of the pieces of it. But you would never really have the opportunity in school to do this, so it's kind of talking about something that you might have very vaguely saw somebody do, but you don't ever really get much time to practice this in a real clinical setting, even in most places up till you even graduate, and then you maybe get to do your first one after you're actually a registered nurse in a hospital. These are just a list of some of the different blood products that are available in hospital. You do receive these and get these out of the blood bank when they are ordered. And again, all of those would have to have a specific physician order for not only the type, but the amount of units or bags that they expect to be transfused. This is just a review, again, a slide we've used in class, just to kind of also make you aware, again, about the reasons that we do give blood transfusion. There's usually from a loss of blood or from a loss of a particular formed component that needs replacing because it's at a low level. And here you can kind of see in the formed elements what the typical levels for platelets, leukocytes, and erythrocytes are in the blood. So pre-transfusion, usually the patient has to have the reason for the transfusion explained to them. Most places now that is a physician's responsibility, but nurses do reinforce and provide more details sometimes about the actual lab values that make it necessary for a person to get transfusions, some of which we've been covering in class in terms of hematologic disorders that patients have. Every time a transfusion is given, you have to have a very set coded reason that the transfusion is being given, otherwise you're not allowed to give it. So usually the physician will set that, but occasionally there'll be other forms or things that require you to go pick up a unit of blood, and you've got to know that reason as well. So is it their hemoglobin's below a certain level? Is it they're having active bleeding? Things like that that are already set as reasons to select. You'll find that usually in the physician's order itself. You have to make sure that a written consent for transfusion is in effect. And that's a key component. A lot of times physicians obtain those. Sometimes when a person has surgery, it'll be part of the surgical consent in that area as well. And all those consents have varying levels of time that they're in effect. Some hospitals will have in their policy that a blood consent is in effect during that hospitalization. So you wouldn't get a separate consent for every bag that you administer, for example. While some other places, if it's all they do is oncology, they may say that a blood consent's good for a year that stays in someone's record, just for convenience. The other piece of that is, you notice on the slide it talks about a BBID band in place. And what that is the blood bank will have a very set ID band that is placed on the patient when a type and cross match of blood is drawn from them. And that number is part of the checks that is done in terms of verifying that that unit really does match up with that patient order. Pre-procedure, you're going to want to do several other things. You want to make sure get a set of vitals, and really look at those and see if there is an elevated temperature. You will want to notify the physician before ever giving the blood transfusion, because often the physician may order some pre-medication, like with some Tylenol and Benadryl, just because blood transfusions, if you already have a temperature, you might end up having a higher temperature in response to the blood being given to you. You also want to verify with the patient and or their family if there's been any history of transfusion reactions and what types those were, so that you can kind of tell whether somebody's a little more susceptible to have a reaction and be able to watch them very close if that's the case. With the IV itself, make sure that it is a working angiocath, no swelling or redness, and if it is, you'd want to start a new one. In terms of adequate size, you usually want it to be at least a 20 gauge angiocath, and larger bore if possible. And then you want to get the right tubing set to go with the type of blood product that you're going to get. And then you usually can go or send someone to obtain the actual blood product from the lab, and different places will have some different mechanism for picking up the blood, whether that's scanning a badge or filling out a form that has to denote some information. But you typically are going to, by facility policy, follow what that is. And you're going to have to carry that blood back from the lab in a biohazard cooler. And the cooler is to make sure that the blood stays cold, and the blood can stay out on the unit without getting administered based on how long that cooler is able to keep that blood at a specific temperature. So in some places, they may just have a regular cooler that doesn't have like a lot of ice or some kind of component in it. And so for those, you really are going to have to know what the set time limit is for that. I've worked in some places where if it was out more than 20 minutes, then if you decided you weren't going to give the blood, it had to be returned immediately back to the blood bank, or it had to be destroyed. And you don't want to be in the habit of wasting blood products. They're a very valuable commodity. In terms of packed red blood cells, they are usually 200 to 250 mLs per a unit or a bag. They also come in washed cells, meaning that they have kind of cleansed them so that they don't have a lot of white blood cell fragments in them that can make a person more likely to react to them. The purpose of packed red blood cells is to increase the oxygen carrying capacity, bringing the hemoglobin up from less than 7 if it's just an anemic situation, or if it can be usually a hemoglobin of 7 to 10 if the patient's severely symptomatic in terms of low blood pressure or bleeding disorders. Main nursing implications are going to be that it requires an ABO and RH antigen compatibility test be done, as we talked about with type and cross match. You're going to have to do documentation, vital signs, clinical monitoring, and you really want to watch the patient for fluid overload, because you're usually giving these unit, and sometimes they're ordered 2 at a time. It's quite a bit of volume in a short period of time. Post-transfusion monitoring, you stay with the patient in the early phase of the transfusion. It's known that they are most likely to have a reaction to blood in the first half hour. So during that time, you want to make sure that other patients' concerns are kind of addressed, or maybe you have a buddy that kind of watches out for some other things. You want to document the start time of the blood when the blood actually reaches the patient. So, you, as with any kind of IV bags and things that you hang, you may scan it and it puts a time in there, but at that time when you turn on that pump, that medicine is not going to reach the patient for probably a few more minutes. So with blood transfusions, you run the blood on down through the tubing, and then you document your start time as the time that the blood way down at the tube and at the angiocath is actually starting to go into the patient. So remember that. From that start time, vital signs in most facilities are going to be, you're going to get another set of vital signs in 15 minutes from the transfusion beginning, and it must be exact. So it's not 14 minutes, it's not 17 minutes, it is 15 minutes on the nose. It has to be exactly precise. And then vital signs are also obtained usually at the 1 hour mark from when the blood was started, and then hourly throughout the rest of the transfusion, depending on how long it runs. You might ask, who does vital signs for blood transfusions? It's been my experience that as a nurse, you can delegate that, but because these things have got to be exactly on the hour marks and exactly at 15 minutes, you're better off to just do these yourself, and unless you've just got a nurse aide that's really precise, that's the best thing you need to do. It's important to note that a unit of blood cannot hang longer than 4 hours. So if it's still hanging there at 4 hours and hasn't infused, it has to be wasted, the rest of it. And to kind of set these up, you have to have a normal saline line on a Y-type blood setup, to where you cut off the saline, prime the saline first, then you hook up the blood when the blood's ready to go, cut off the saline, turn on the red blood cells, and let them run. So when you're taking it down, you're going to cut off the blood line when it's finished, and then you're going to open up the normal saline line again so that you flush all the remaining blood cells that's left in that tubing during administration, so that the patient really gets the full transfusion of blood. Make sure that you document the ending time of the transfusion, and usually it requires you to mark that there was no transfusion or absent of a transfusion reaction. And if you have a second unit that is ordered after this, you can use the same tubing, and normally you'll give each one of these units over about an hour to an hour and a half. Imagine if you have somebody that's very, very fluid overloaded, or has congestive heart failure or respiratory problems, that they may not be able to tolerate a unit of blood as fast as someone else, in terms of them feeling shortness of breath, or feeling like they're getting too much fluid circulating, or making them sound kind of wet respiratory wise. So just pay close attention to breathing status during transfusions. Whole blood is another component that can be given. It's not ordered all that often. It comes in 500 mLs per unit. The main purpose for it is to really give full volume replacement.